Good morning and welcome everyone. Is it working? Okay. All right. So again, good morning everyone, and it's a pleasure to welcome you to today's Grand Rounds that feature an exciting match between Dr. Burke and Dr. Goessl. See who's going to win. I'm kidding. But it's actually a great opportunity to discuss about something that used to be more controversial than is now. We actually have a big trial running, which is called the Rebirth trial, that looks at radial versus femoral. And a big issue with access has been that we always say, well, radial has less bleeding, but is it femoral done the proper way? And I think here will be one of the leading places to do it the proper way with ultrasound guidance and angiography and using closure devices and fluoroscopy. So I think femoral access done properly might not be quite as bad as you think. Now, I'm a little biased, as you can tell, but I think the trial will tell us. It's a 3,000 patient trial. We're making some good enrollment so far here, and we're hoping to expand it to other sites. But I think to better explain the rationale of the study and how it fits in our current interventional practice, we have an amazing group here that Dr. Burke and Dr. Goessl are going to discuss about the pros and cons of technique. And each one of you can make your own choice about which exercise at this point in time is good or not, pending the results of the Rebirth. And following that, we're very privileged to have here one of the world experts on COVID and myocardial infarction, Dr. Garcia, who's going to present about the NACMI Registry and the current status of the field, still very topical since COVID is coming back with the Delta variant. So again, thank you all for being here this morning. And without further delay, Dr. Burke will kick it off about femoral access.
So we're actually talking today in part about different access for angiography and PCI. There are two main ways to do that, of course. One is radial versus through the wrist. The other is femoral down through the groin area. This has been a topic that's been debated for years in the cardiovascular literature, and to which I say, really? Is that still a thing? Are we still talking about this now? I think the data is pretty conclusive, and we'll show you, and hopefully you'll be able to make your own educated decisions, just like deciding whether or not to take a vaccine. So this is a very common occurrence in femoral angiography. This is a femoral hematoma. This is a pretty good hematoma. It's not too bad. That's a real hematoma. That you see with unfortunate frequency in femoral access. You don't see that really with radial access, and they can also get infected. This is necrotizing fasciitis that needed to get operated on. And another dreaded complication or common complication of femoral access you can see here is what's called a pseudoaneurysm. This is a large collection of blood where the arteriotomy site has not been closed off, unfortunately, and the blood washes in and out of a chamber that has been made by the blood. And these things can rupture or become extremely large. Shown here is a very large pseudoaneurysm. Up in the upper left hand, the upper right hand is angiography of that. This needed to be taken care of surgically, and that's the exposure of it there in the left lower quadrant, and then the final post-op, what the person had to go, all just because they needed to have femoral angiography. The most dreaded complication of femoral angiography, of course, is retroperitoneal hemorrhage. And what happens in that case is the blood actually dissects up and goes over the pelvic brim into the pelvis down in the retroperitoneal space. It essentially encounters no resistance whatsoever, and the blood can continue to pool and pool and pool. And this can actually become left unchecked. This can be a fatal event. This is, you see here, this large collection of blood here down in the pelvis that extended up into the abdomen. They're basically obliterating the right kidney. It was such a large bleed. So this is a surgical emergency and is excruciatingly painful for the patients. There's a number of ways to stop femoral bleeding. This is one of the older compressor devices, which is, I think of sort of as medieval. They're extremely uncomfortable for patients, and it would be best avoided if you could. Femoral bleeding is such a big problem that SCAI actually developed a quality initiative to prevent and manage major femoral access site bleeding. So think about that for a minute. This is something that we do. There's so many complications from it. It's such a problem. SCAI took it on as a problem. And what did they suggest? What's their recommendations as to how to deal with that? Their first recommendation was to use radial for instead of femoral access for PCI, if possible, especially in patients at high risk for bleeding, including acute coronary syndromes. In the Rival trial, transradial PCI was associated with a 64% reduction in access site bleeding compared with transfemoral PCI in patients with both non-STEMI and STEMI. And we all know that the Europeans tend to be ahead of us, right? I mean, Mario will be the first person to tell us that the Europeans are much more sophisticated than we people on the other side of the pond here. This is the STEMI guidelines from 2017 from the European guidelines. The class 1 indication is to use radial over femoral access. It's a class 1 indication. That means that's what you should do, period, for STEMI treatment. Well, what about everything? And if you look at major bleeding, it just occurs more frequently with femoral access, period. This is a large meta-analysis. The first one is both stable ischemic heart disease or acute coronary syndromes, and there was substantially more major bleeding in the femoral case. So radial was preferred in this. Major bleeding, particularly in acute coronary syndromes in the bottom. Again, much preferred to use radial. They have a much lower complication rate. Major vascular complications, also lower, not just bleeding, but pseudoaneurysms and other things like that, also favored radial access. Well, what about mortality? If you look overall, the mortality, if you include stable ischemic heart disease and acute coronary syndromes, there's probably no difference. But if you look just at acute coronary syndromes, let me repeat that. The mortality is lower if you use radial access. This is from the Rival trial. The mortality was lower radial femoral study published in 2018, Matrix. There was also improved outcomes with radial over femoral access. What's the most common rationalization I hear for using femoral access is it's better for high risk or complex interventions. Well, is that really true? Is there data to support that? I'm going to suggest that there isn't. The highest risk PCI that we do is left main PCI. And if you look at bleeding complications in radial versus femoral in left main PCI, of course, radial has lower bleeding. It has lower access site bleeding, and it has lower bleeding of any kind. Well, what about mortality? In this meta-analysis, it showed that there was a lower mortality for radial access for left main PCI than there was for femoral access. Let me repeat that. There is a lower mortality for radial access than there was for femoral access. And what about the most complex intervention that we do? That's chronic total occlusions. They're the toughest, they're the lowest success rates, and they have higher complication rates in general compared to regular PCI. They require 2 catheters to be placed. This is a meta-analysis that actually came from one of our fellows, Mike Megali. He looked at a meta-analysis of 9 observational studies. This number have been randomized in CTO. In the radial approach, there was almost 4,600 patients. In the femoral approach, there was about 6,000. The CTOs were slightly less complex in the radial approach, but there was a similar success rate. So the success rate of getting the CTO open without a major complication was the same, but there was lower risk in the radial approach. There was a lower risk of access site complications. There was a lower risk of major bleeding. And there was a similar risk of overall Q-wave myocardial infarction, mortality, pericardial tamponade, coronary perforation, or emergency bypass surgery. So thus, in the most complex and in the highest risk patient population, radial shows an improved outcome. That's all I got.
This is biradial CTO, or
most of these are biradial, yes.
So we didn't know our talks, but I knew exactly what he would say. Maybe. So let's just focus on the two major things, right, that Nick said. And Nick said mortality benefit, right? And then Nick also said the bleeding question, right? So those are the main questions. But as you probably noticed, there was like 10 slides on like the craziest bleeding complications you can imagine, which were probably from 20 years ago. These slides were already like, darkened. And then when it went to mortality, the slides got a little sketchy, right? It kind of like, I thought they were not as impressive as the rest, but let's see. So first of all, disclosure, I've never lost the debate. So let's see. And then pre-debate, I thought, this is exactly what Nick thinks, right? But you always have to be careful. Yeah, because something looks like this, right? Anyhow, so why go radial? Earlier mobilization, I thought because of the bleeding risk and all of that. There's actually a very recent publication here, not high-ranked journal, but a recent publication, and that suggests actually you can do immediate and post or 2-hour mobilization with closure devices. And it seems like there's actually not a crazy, let's say, significant difference in a very immediate and 2-hour mobilization. So even if you say radial, less bleeding risk and early mobilization, maybe if we do like Manu suggested, a very good femoral access and are really careful in educating, who's doing the post care, potentially there's some opportunity there as well. Then another thing is that he didn't mention is like, because we have to do the procedures, right? So how about the radiation? I think that's still an open topic. And this is a study also from earlier. I think people haven't really done any updated studies, but one thing is for sure, the operator as well as the patient are potentially exposed to higher radiation, especially if you do then the left radial approach, which sometimes is requested by our colleagues. Our rooms are not set up that well. So if I reach over, I'm constantly getting all the radiation from the patient. And if you're not maybe a very versatile radial operator, your operation time will be longer. So your radiation time is longer too. So there's a lot of caveats there. So overall, for me, that's a downer. The mortality myth, I knew he would say that, right? So there have been these studies, the meta-analysis, of course. And as you can see here, and I just highlighted the big topics because we only have like 10 points. So overall, if you just read the numbers, you always see, yes, there is a statistical difference. And then you see also the number needed to be benefiting or treat. And you see there's a pretty high numbers, right? So if you think about like aspirin therapy or so, how many people do you need to treat with aspirin and a STEMI to actually have a benefit? What's your suggestion? 1,000? No. I mean, huh? No, actually it's like 30 or 40, right? So it's so strong that this is a clear outcome, right? So that's one of the things I learned as a fellow, these numbers needed to harm or treat, right? So 160, I think, is somewhere to benefit. That's a pretty high number, actually, right? Now, I did give you this, though. There is this meta-analysis of 2016 that suggested the mortality benefit. Now, let's go to the weeds, though. So these are these meta-analysis that he mentions, right? You see these big graphs. And just to be clear, in stable, sorry, I hope can you see my, yeah. So stable, no difference, right? So if you have a stable patient, there is no mortality difference, right? So if you then have an NSTEMI, there's also, sorry, I'm sweating. There's also no mortality difference, right? The one thing that is the last mantra is basically in STEMI. In STEMI, there was this mortality difference, right? And even that people now looked at a little bit more closer because it's majorly driven, and I'm not a super special meta-analysis expert, but Ross is here. So there's a couple trials with high numbers that drove that mortality benefit, right? And absolutely, my friends in Europe put that in the guidelines because that's all there is, right? So let's go through the next step here, if I can. Oh yeah, no, I went. So this is one of this big trials, the Rival study, because if you think of his slides, right? He mentioned the Rival trial, but he didn't mention the original Rival trial, right? He didn't mention the Lancet publication. He mentioned the other JAK interventional that was done afterwards, the analysis, right? So this one actually, vascular complications was the difference, right? So, which is clear, right? If you don't use ultrasound, if you use this huge needle and blindly stab it into the femoral artery, you know, every now and then you will miss it, yeah? Or you will go too high or too low. I mean, that's clear, right? Because of all the variations. But like if you do rebirth or if you use ultrasound guidance, you should probably, hopefully if you see that in rebirth, you should see a difference. Now then, of course, here comes this one that everybody then wants to mention because this is the one that supports the whole notion of mortality benefit, right? Here they say, yeah, in STEMI patients, there is maybe a difference, right? But of course not in the lower risk patients, right? And it's all about bleeding risk. Maybe the bleeding here, bleeding there, bleeding this, bleeding that, right? But then there's a whole subgroup of statisticians that went back and said, there's this difference of mortality, about 2%, that cannot be explained by any data set inside that trial because look like low rates of bleeding of 0.8 and 0.9 in both excess groups. So something is off, right? What's off with that? Anyway, eventually people said, you know what, we have to look at STEMIs, right? We really have to randomize people. Let's do another trial. That's the Safari trial. No significant difference. Just that. Then Kapadia, I don't know if he's a Radial guy. Yeah, well, you know, maybe it's the real world, statistical, blah, blah, blah. So some sort of suggestion why there might be a difference. But this is something you have to dig deep, right? You have to go to the supplemental thing and then you find the updated, because whatever, the editor decided, I don't want to have this in the main paper. But this is the updated meta-analysis with Safari, right? And now you're going like, okay, there's a little difference still in the mortality, but almost it's gone, right? So then we're having nothing in stable, nothing in NSTEMI, maybe something in STEMI, right? So that's how it looks like right now. Well, the guidelines will not change because this is still there, but it's not as Dr. Burke has described it, right? So inclusion stable and NSTEMI, absolutely nope. Radial and STEM, for me, Safari debunked this whole mantra of like, okay, definitely a mortality benefit if you do STEMIs with Radial. Yeah. And then like Manu suggested rebirth. So if we do all of this ultrasound guidance, always right at the bifurcation or just above, maybe that looks all a little different. So, you know. Oops.
percentage, there's some of us who are, pretty much primarily radial, and some people that only use femoral. In honesty, I think that the rebirth trial is the right thing to do here. I think that the modern techniques that we use probably, make a difference. Is there still going to be some little higher incidence of bleeding in small complication rate? I think yes, they're probably rated, but I think that's going to be small in the end. I do it. Uncomfortable. Make them sit up immediately. You don't have to get. I don't know if the percentage wise, are we even 50-50?
I don't think so.
Yeah.
I would say it's probably 30% radial, 70% femoral. That's my sense. Yeah.
And Dr. Burke, just to make sure I understood correctly, the trials that you were talking about with femoral, they were not necessarily with closure devices?
No, they some of the real old stuff was not. They were and the closure devices. It can go bad in a big way. So they've never been shown to my knowledge, ever been shown to decrease complications.
And Nick and Mario, you want to comment on the issue of training and how that affects the femoral? It has been reported, and now a lot of fellows are coming out of training with radial experience, and that may not translate to the groin as well, and how it's important perhaps to keep a healthy balance between the two.
Yeah, I think over the last 2 years, maybe 2-3 years, the fellows that we see in interventional or structural, and of course there's always this new situation, new attendings, and so take this all aside, this nervousness maybe in the beginning. I think it's very clear to me that a very well-trained fellow in ultrasound guided access does not exist right now. Maybe in out there yet, but in general not, because I think that either there's radial access and that might be not ultrasound guided, so focused on radial that they almost forget about femoral, right? And then femoral definitely not with ultrasound guidance. So I think that I really applaud our efforts to do everything radial or femoral with ultrasound, so that you get used to actually the look and how you use the probe.
Mm-hmm.
And I also, we'll see the data, but I also think that if you really always know exactly where the bifurcation is, and if you do a criteria stick, even for the closure devices, then a big benefit. So
Yeah.
see, but
I'm optimistic that'll be the case. I think your point is that people need to be facile with both techniques, and that's important. And for people who've had bypass surgery, I go femoral on those patients. That's a pretty good segment of our population that have had bypasses that we need to do angiograms on. So we need to know how to do that really well. And obviously for the big bore stuff and being able to, as people do more things like, well, just balloon pumps or Impella or, even ECMO, you really need to know how to do that well. And that requires, like any skill in medicine, it requires a great deal of experience.
if you look at the complication rates of these major procedures like TAVR, other procedures, the highest number of complications is usually vascular, right?
Mm-hmm.
And so I think if we don't get trained in a procedure where the operational experience in that particular field femoral is maybe the denominator for complications, I think that's just not good. We have to definitely have a good femoral experience in order to, because everybody wants to do the complex procedures after their fellowship, right? Everybody's asking, right? But if you don't know how to get access in there, then unfortunately you will have complications.
The cases you mentioned are not the ones you want to learn. You don't want to learn femoral during an ECMO or a TAVR. You want to learn with a 6 French sheath without heparin first, and then PCIs, and then all this large bore access. So, all right, nice discussion. Nick has to go to Waconia, so we're gonna excuse him now. We're gonna switch gears a little bit for the last 30 minutes of the talk. I know what you're thinking, how many interventional cardiologists we need to put together 1 grand rounds. The answer is 3. I'll be talking about the NACMI Registry, which, as you know, has been supported by the foundation here. And we've done quite a bit of work on this interaction between the COVID-19 pandemic and STEMI. So these are the 3 bullets for my talk. I'll be first mentioning some of the data from last year when we first noticed a significant reduction in STEMI activations and what may be the causes and the consequences of that. The relationship with late presentations and out of hospital cardiac arrest, and finally moving to NACMI and some of the work we are still doing with it. So let me put you back in March 2020. We were preparing in the cath lab, creating all kinds of documents and protocols to receive these patients with chest pain and maybe COVID, and how we're going to triage them. Are we going to, these level 1 patients that are coming from other hospitals, are we going to send them to the ED to get tested? How are we going to deal with a PPE issue? Remember in New York, we saw horrific images of nurses not having access to masks, et cetera. And we just sat in the cath lab and waited and waited and waited, and the patients never came. And so there was this sort of hysteria in Twitter about where are the heart attacks. And so we were able to quickly put together a number of centers, the Midwest STEMI Consortium, the 4 sites plus other sites in the East Coast and 1 site in the West Coast. And they gave us data about their STEMI volumes for the last year, and including March and April. And as you can see here, there was a significant 38% reduction in STEMI activations in the early phase of the pandemic. We then expanded that analysis. This paper has received a lot less attention than the first one, but I think it's actually more meaningful. We expanded this to 17 STEMI programs. And we have programs in the 4 big geographic regions in the US. And we noted that there was actually a reduction everywhere in the country, not just in these high volume centers, and many of them cluster in the East Coast. We also noticed there was a significant increase in door to balloon times of approximately 20 minutes. In the early phase of the pandemic. So this was clearly disturbing. It was real. It was something that people were talking about, and we could finally put a number to it. And then more importantly is what do we do with this data? So what you're seeing here is the drop in STEMI volume expressed in standard deviations from baseline. So 0, if you're at 0, it means that your program hasn't really dropped relative to pre-COVID levels. If you're 1 standard deviation to the left, that's the magnitude of the decline. And we have 2 months here, March and April, expressed in different colors. I don't know if you can see that, but green is essentially April and purple is March. Some programs like Christ Hospital in Cincinnati rapidly responded to this decline. And we got Tim Henry in the media talking about chest pain and how you have to go to the hospital. Still, hospitals are open for business, and people should not forgo care. But other centers still in April, we're talking now 2 months into the pandemic, still had a significant decline in STEMI volumes. So this gave us some clues as to what are the interventions that needed to happen to change that. The other was, what is driving this? Why are people just not going to the hospital? Well, it's multifactorial for sure, but one of the main drivers was COVID incidence. So you can see that this is mostly the East Coast. So those parts of the country that had a much higher incidence of COVID, so this is in relationship to the median COVID incidence in the US, had a more pronounced decline in STEMI activations, almost 50%. And to me, the big driver was the stay-at-home orders, so the lockdowns. So the lesson here is when you tell people to stay home, they do that. They stay home. When you tell patients, if you're short of breath, if you remember this, that was the message in the early phase of the pandemic, stay home for 2 weeks, self-isolate, and that's exactly what they did. And so the message needed to be calibrated, because then we went back almost a century in our STEMI care. We essentially were effectively recommended bed rest for patients, many of them with heart attacks. And this is actually a little bit of joke, but was the prevailing view of how to treat heart attacks in the 1950s. Bed rest, the armchair treatment. That was the title of the paper in JAMA. And so we were at risk of losing 3 decades of progress in STEMI care in 2 months. So all the thrombolytics trials, all the primary PCI trials, we were essentially going in the opposite direction very, very quickly. And so where did the heart attacks go? And now we know the answer. Many of them went to the morgue, they never made it. So this is data from Europe. This is data from Paris. They have a very sophisticated cardiac arrest system where it's centralized. And you can see there was a significant spike in cardiac arrest during the lockdowns in France. So that's to the left. To the right of the slide, you can see the percentage of patients that actually were resuscitated and made it alive to the hospital. Typically, the number is about 20%. This dropped to 10%. So people are dying alone at home, and the paramedics are arriving late. And you can say, well, that may be COVID. These are COVID patients that are just dying at home. So, well, in Italy, they actually did a more sophisticated study where you can see here in orange is the number of cardiac arrests for 2019. In blue is for 2020. You can see a significant increase in 2020. And actually, they had COVID testing for all these patients. And only 1/3 of that excess was related to COVID. The other 2/3 were probably related to not just heart attacks, but also cardiovascular emergencies in general that were not going to the emergency department. This is data from New York City, 800% increase in cardiac arrest during the early phase of the pandemic, 800%. Once again, this is not just COVID, it's the increase in cardiovascular death. The same thing has happened with the stroke. This has been well documented. This is the use of neuroimaging for acute stroke care, significantly drop after stay-at-home orders. Visits to the emergency department. So this is expected versus observed. And you can see in March 20, when the orders to shelter in place went into effect, there was a significant reduction in the number of visits to the emergency department. So the bottom line is, if you tell people to stay home, they will stay home. And those who venture out, they do so when they have no other option. They present very late. These are 2 cases from our center. Within a week, we saw 2 mechanical complications of acute myocardial infarction. This is the first one, a 67-year-old patient from Cambridge, acute RCA occlusion. She waited 14 hours because she thought she had COVID. When she presented in the emergency department in heart failure, the artery could not be recanalized. It was late presentation, went home, came back a week later with a BSD and died after surgery. And Said Al-Sida, we published this. We also had a second case, a patient that didn't come to the emergency room because she feared contracting COVID in the hospital, as many patients did initially. Presented a week later with free wall rupture, palliative care, and die in hospice. So these are 2 preventable deaths. And this is something that I think we typically see 1 patient a year, maybe. We saw 2 in a week. And Jack case reports actually put together a special issue to collect all these cases. So that's one part of the story, which is how COVID indirectly affected STEMI care. The second part of the story is how COVID also can oftentimes coexist with heart attacks, and what are some of the implications. We know that from the early days of the pandemic that patients that have cardiovascular disease have excess risk of mortality with COVID. They're more likely to be hospitalized, they're more likely to need ICU care, and they're more likely to die from the disease. That's why they were moved to the front of the line when vaccines came out. About 30% of patients had evidence of myocardial injury. So if you measure troponins in everybody, about 1 in 3 will have troponins that are measurable in the hospital. There was also talks about how do we treat these patients. And the Chinese, the first ones to deal with this pandemic, reported a shift to pharmacological reperfusion. So don't even try to bring them to the hospital. Keep them in the COVID units, give them thrombolytics. That was sort of the recommendation that came out of China early on. And then you may remember this paper. It was actually a case series that made it to the New England Journal of Medicine from New York City, reporting a 72% mortality with COVID. So many people thought that this was essentially futility to even bring these patients to the cath lab. You have a risk of exposing everybody, and the benefit is really not there. So this was kind of the data that was available to us at the time we designed NACMI. There were 5 studies, all of them very, very small in size, and reporting various numbers from 72% in New York City for mortality to about 12% in the international experience. So really a mixed bag, very hard to learn anything from this. And this was obviously the cardio Twitter craziness, people reporting this type of EKG, clearly consistent with a STEMI, go to the cath lab and don't find anything. So the concept here was there's a lot of non-obstructive CAD or STEMI mimickers in patients with COVID. They may have myocarditis, they may have something else, so don't even take them to the cath lab. So we decided very quickly that this needed to be addressed at a kind of large scale level. We partnered with SCAI and its Canadian equivalent, the American College of Cardiology, and we used the Midwest STEMI Consortium as our control group to create this prospective observational registry, which we call NACMI, North American COVID-MI Registry. Because we wanted to be inclusive, we wanted to essentially capture every single patient with ST segment elevation MI. We did not exclude patients that were treated medically. We did not exclude patients that were treated with thrombolytics. And we obviously included patients that went to the cath lab. So we didn't want to make a judgment call. The second issue that we had to tackle when we designed NACMI was how we're going to deal with people that are considered PUIs, persons under investigations. And everyone was, if you remember earlier in the pandemic, everyone was a PUI. If you could not test the food right, you maybe had COVID. And we need to get you tested. And if you coughed 2 weeks ago, someone decided you were a PUI, how are we going to deal with that? So we included COVID positive patients, but we also included persons under investigations in a different category. And that was actually the right thing to do in retrospect, because it allowed us to compare the two groups in addition to NACMI, in addition to, I'm sorry, the Midwest STEMI Consortium as our control group. So we ended up with 3 groups: the COVID positive patients, the suspected COVID positive or PUIs that later on rule out negative, and then the Midwest STEMI Consortium patients. The main findings were published in JACC earlier this year. We did the first cut for TCT, 230 patients, COVID positive, 495 PUIs. And the key findings are shown here in the central figure. So for the first time, I don't think we're going to find any other STEMI registry where 50% of the patients are from ethnic minorities, African Americans, Hispanics, 50%. The second finding is the presentation. Cardiogenic shock was common, about 20% of patients. In-hospital presentation was also common. About 10% of patients actually were not in the hospital for the STEMI. They developed the STEMI while in the hospital with COVID. And then the number one symptom was not chest pain, it was shortness of breath, actually. So we told all these patients to stay home and self-isolate for 2 weeks. Actually, it could have been a manifestation of a heart attack. Now, mortality, very, very high. So our primary endpoint was MACE. It was a composite of mortality, stroke, need for another angiogram in the hospital. But it was driven almost exclusively by mortality. So you can see here, MACE was 36%, mortality was 33%. Very, very high in hospital mortality. This is mortality for non-COVID patients with cardiogenic shock. This is very, very high. And stroke also was significant, about 3%, which is consistent with the prothrombotic state that we see in these patients. We set a very ambitious goal, and I thought Tim was crazy when he said we needed 500 patients. So we're never going to get there. Well, we already got there, and we exceeded the mark. The first data was presented at TCT, already published in JACC. We presented a second updated analysis at SKY. Dr. Degani from Canada presented that. Now we have exceeded 500 patients, and we're following these patients, the survivors, we're following them for 1 year. So we're going to have some follow-up as well. So this is the representation. As you can see, there is a lot of variation. Our center, we don't treat anybody as a PUI, so we only have COVID patients. A lot of centers still do a fair amount of PUI, so they contribute this to the data set as well. You can see most of the contribution comes from the United States, some patients also from Canada. You can see the numbers on top, but it's about 20 plus patients from Canada, the majority, several hundred from the US. With regards to this is the second data cut that we did for SKY, but the overall message hasn't really changed. Still 55% of patients are non-Caucasians, which is very unique for a STEMI registry, and 44% have diabetes. So these are the typical phenotype of a patient in NACMI. It's a minority patient that is obese with diabetes. The common presentation with dyspnea, about 50% had dyspnea. Abnormal chest X-ray findings, very common, 45%. In-house presentation, about 7%. So what about reperfusion strategies? Remember how we discussed that these patients should not go to the cath lab, they should get thrombolytics. Well, that turned out not to be the case. In fact, 80% of patients in NACMI underwent angiography. And the #1 revascularization strategy for those patients was primary PCI. So medical therapy was offered to some patients that had no culprit, but it wasn't a large group of patients. So about 20% of patients that went to the cath lab had no culprit. The other treatment modalities are in sync with what we know about coronary disease. Some patients got surgery, some got thrombolysis, and some got facilitated or rescue PCI. When you compare that with the PUIs, clearly we had more patients with no culprit in the COVID positive group than in the PUI group. So 4% versus 22%. The door to balloon times, and we were kind of glad that we had a historical control for the Midwest STEMI Consortium, was somewhat delayed, about 10 minutes, but not terribly so. So doing this rapid testing, I think, became sort of a standard, or just taking these patients with a mask to the room and treating them. And so that the proportion with door to balloon times less than 90 minutes was still about 2/3, less than pre-COVID, but not terrible. Mortality remains very high, even though we have now more Canadian patients. We have almost 300 patients total, but mortality remains very high, 33%. And as expected, more ICU stay and more length of stay in general. Now, the other interesting part, you may ask why the PUIs have 11% mortality. That is quite high. And so this PUI is interesting because we don't really know who gets put in that box. We didn't want to legislate when we designed NACMI. So if you call it a PUI, we accept it as such. So we are here, we have no PUIs. There are centers that call every single STEMI a PUI. But you can see that it have an 11% mortality, and that is, in my view, driven by cardiac arrest. So a lot of cardiac arrest patients, you don't know anything about them. They die somewhere, they are brought to a hospital, and they're called PUI. So in that PUI group, we have, I think, a 20+% incidence of cardiac arrest. And that may be the driver of that very high in hospital mortality. So this is a typical NACMI patient. This is actually a patient from our center. Was admitted in the hospital with COVID, in the ICU with ARDS. On hospital day 3, while intubated in the ICU, he developed a STEMI. You can see unequivocal evidence of ST segment elevation. Taken to the cath lab, had an occluded RCA, and that got fixed. The next day, he goes back to the ICU, and now he's in shock. So he gets put on, come back to the cath lab, he gets put on BA ECMO, and this is his CT. He has an intracranial bleed, and he died on day 5. Now, I mentioned this because when we submitted NACMI, the reviewers, there's always a smart reviewer that asks, were you able to attribute cardiovascular and non-cardiovascular death? What are these patients dying from? And the answer is we don't know. They have multi-organ failure. This is how these patients die. They don't die from the STEMI necessarily. They die with the STEMI, they die with this X-ray or CT, with a stroke, with intracranial bleed, etc. So it's multi-organ failure. It's very, very hard to attribute the cause of death. They have multiple organs that go down at the same time. So what are the predictors of death? The two big ones are if you're intubated, so if you have severe concomitant lung disease, or if you're in shock. And you can see here that performing PCI was somewhat protected. There are all kinds of biases that went into the decision to take people to the cath lab, so take it with a grain of salt. But it's one of the few things that seems to be helpful. So this contradicts the Chinese experience. And in fact, when they published the Chinese experience, there was excess mortality in the patients that received thrombolysis. So the right approach is still to take these patients to the cath lab for PCI, unless they're perceived to be futile. Dr. Degani will present this at TCT. We're working on a risk score for mortality, but I just want to highlight two things. One is the two variables that have the highest weight are mechanical circulatory support and mechanical ventilation. So if you have one of those two, you automatically go to the moderate classification, moderate risk of mortality. So being intubated is not a good thing for these patients. Now, the use of circulatory support was fairly common. About 13% of patients, both in the COVID-19 category and the PUI, needed MCS. And the devices used are listed here. The number one is still the intra-aortic balloon pump. And you can see that if you need MCS support with COVID, your mortality is 60%. Very, very high. So if you have COVID and you're in shock to the point where you need one of these devices, the mortality is very, very high. And this is important because now we're having a second wave. We have many states like Alaska don't have Alaska. I learned the other day, they don't have ECMO. So when you have limited resources and you have to make decisions to transfer patients to perhaps another state, well, you know that if you need that device with COVID-19, the chances of surviving are not very, very high. So we think that our risk score may be useful to help triage patients. Now, interestingly, when you compare COVID positive with COVID negative patients and the type of NCS devices they use, there was, as expected, perhaps a higher use of ECMO in the patients with COVID-19 infection. And we believe this is BA ECMO that can do both support the circulation, but also oxygenate. These are some of the analysis we are planning to do. We, as I mentioned, 1-year follow-up of survivors. We have an angiographic and an ECG core lab, both in Canada. We are going to conduct a gender and ethnic difference analysis when we close the study in December of this year. We're going to do obviously the Canada versus USA comparison, the risk score, and the MCS, which is ongoing. I really want to acknowledge the role of the foundation. The study was supported by the foundation. We have the database here. This was designed just to give you perspective in the midst of a pandemic with no in-person meetings, over the phone. Ross, the statistical team, phone calls Saturdays, Sundays, until we got this up and running with the sky. So this would not have been possible without a lot of help from a lot of people. So thank you for that support. We also received some industry support from Medtronic and Avovascular, so thank you to them as well. With that, I'll finish it, and we open it up to questions if you have any. Bhavana.
I mean, this is very close to home because we had the some losses of COVID, not because of COVID, but because of the cardiac disease that was not. So my question to you also is, are you seeing where like everything else, all the other cancer, diabetes, hypertension, everything. I mean, I'm guessing patients are afraid to go back to their providers get? I mean, are you seeing it's getting any better now that it's been
Yeah.
longer that the pandemic is
There is-
ongoing? Or are you seeing that now, especially with the Delta variant again, fears going up? Is that kind of coming back? Like, are we reliving
Yeah.
2020 again?
I think we're not, a group is not directly investigating that, but there is data to suggest that yes, it did get better. And yes, it affected everything. And breast cancer was one example, for example. And I think our senator had a story, Amy Klobuchar, I don't know if you knew it, she missed her mammogram and was diagnosed with breast cancer the following year. There are all kinds of stories like that during COVID. I think we're now repeating the mistakes of the past. And if you remember when the first lockdown, we even shut down the clinics. And we were treating hospitals and clinics the same way we treated shopping malls and cinemas. And there's no Amazon for healthcare.
Right.
There's no Amazon for healthcare. So I think we learned from that. That was a very indiscriminate across the board shutdown that we didn't repeat. I don't think anyone is thinking about that, doing that again. Even now, which I think is probably the worst we have seen from COVID, at least in the South, hospitals are still operational, clinics are still running, etc. So yes, there is some reluctance from patients to go to hospital, but I don't think it's as bad as it was in 2020, in March and April. Yeah.
Patients are coming back for follow-up.
Mhm.
I mean, I'm guessing you're seeing worse disease too in the cath lab too than before, right? Is that's any better or?
No, I think at least I'll let Mario speak to that too. But my sense is that hasn't really changed now. We've been now up and running for a year and a half with protocols, etc. Everyone is used to it. It used to be we have a COVID patient, and it used to be all kinds of alert. Now it's like next patient is COVID positive. No big deal. Everyone is prepared to deal with it. We do cases routinely. We have PPE, which we didn't have early on. We know how to deal with these patients and the equipment in the room because it has to be close. We cannot bring equipment during the case. So we have protocols to deal with these patients that we didn't have early. We didn't have a clue how to deal with these patients early on. So we learn, we prepare, and we adapted to it. So yes, John.
I was saying those two cases that you showed before, those are the pre-vaccine neuron, is that right?
Yes,
Okay.
yes, yeah, or pre-vaccine, yeah.
Got a couple online questions. The first one is, are you looking at differences between the alpha and the delta variant type characteristics in the health?
Yeah, no, so there are if we made a few mistakes. So we didn't know what delta was when we designed this. So we don't have a way to look at that other than time of enrollment. We also did not put in our data form vaccine yes or no, because there was no vaccine when we designed this protocol. So those are some of the limitations. We can't really comment on the effect of vaccines and the Delta variant. But we're definitely, I personally never thought we were going to get to 500 patients, and we exceeded that. We're still seeing a lot of centers enrolling high numbers of patients with COVID-19 and STEMIs, which to me is a surprise. It's a preventable disease. Courtney?
Great presentation, Santiago. Question about dissemination of this. Do you feel like kind of best practices and your comfort with dealing with various patients, particularly COVID positive, has been disseminated throughout the country, throughout other countries now that other places that might not have this?
Yeah, that's a good point. I would say for the most part, I think in the US, we never really embraced this thrombolytic first approach. We were looking for signals that would indicate that, but that was not every time we talked to one of these sites, and we had a lot of sites in NACMI. No one really was embracing that. In Europe, I think the systems that had to do that, like Italy for a period of time, it was just simply a reflection that they had no capacity. They were overrun. They really had no capacity to treat so many patients at once. But they never believe in the concept, and I don't think it's widely used practice in, at least in the data they have presented. They have also a very similar registry, but it's inclusive of ACS patients and STEMI patients, but they still prefer primary PCI. I think China has been the main advocate of thrombolysis. And even before COVID, they never had the penetration of PCI was never as high as it was on this side of the Atlantic. So I think to answer your question is the US never really deviated from the principles of mechanical reperfusion. Yes, John.
Just one final online question, and it is, have you seen a change in the number of mechanical complications in the current era versus in the beginning for STEMI patients?
Yeah, well, personally, I personally haven't seen any mechanical complication in the last, few months. We had that short period of time where we saw way too many. We saw everyone was reporting that, not just us, by the way. We saw 2 in a week, but Cindy Grimes has collected them all. All the NACMI sites contribute these patients to a database, and I think she's working on reporting that experience now. But I think it was a phenomenon that was seen in the early days of the pandemic. I personally haven't seen any more of that lately. Yeah. But again, Minnesota is not as affected as by the current Delta variant yet as the southern states are. And so, all right, thank you.